I'm very excited about this Peripheral Day teaching session. Here is our 4th annual UCSF Dr. Kline Peripheral Nerve Lectureship, and it's really my honor to introduce Dr. Kartik Krishnan, who is also a fellow of Dr. Kline. He's going to talk today about the primary and secondary reconstruction strategies in brachial plexus and peripheral nerve injuries. I just want to take some time to thank Dr. Berger, who has been giving his support to this lectureship from the beginning and has been really a great supporter of all the peripheral nerve program. So I want to thank him personally about this. And also Dr. Chang, who has been supporting this session as well. And I'm looking forward to work with him in the future. Dr. Krishnan is now working as the head of division of neurosurgery in Germany. But to go back to understand and to look at his education, he has both board certified in plastic surgery and neurosurgery. And like I said, he has done several fellowships, but certainly one of them under David Kline, as you know. So just to give you a little bit of perspective, Kartik is born in southern part of India, born and raised there in a town called Madras, or area called Madras. And he has been in class there and had a very early start in his interest in neurosurgery with a friend that was a neurosurgeon and later on was part of the World Federation of Neurological Surgery. That was president, and he became president later on. So is has done several of his study, like medical studies in University of Moscow. You see him early on, like with his fellow students, and here doing his experimental studies, consolidating interest in microsurgery and transplantation. He had extensive experience in war zone, which brought him to work on flap and reconstructive surgery very early on, as you can see here. So here is some example of blast injuries of the extremities that require microsurgical solution. And without those solutions, the patient would be amputated or mutilated. So, I mean, Dr. Krishnan has a lot of experience looking at this type of lesions and then refining this type of procedure. So here is some example, and very early on he has published already on reconstructive microsurgery with special equipment. Then finally his interest for neurosurgery started on there, and then he moved on with further training, as you can see here. So here's is a picture of him with Professor Jacques. And there's so many, like, you know, that has contributed to his knowledge, both in LA and in South Africa. And then finally, I was really surprised myself to learn that he was in contact and he learned from Peter Richardson that we crossed paths at McGill. Peter was there before that he moved to the UK, and then I took over McGill program at that time. So life is strange the way that people cross paths. And finally, trained under Dr. Kline. And I was really interested to know that Kartik was his last fellow, actually. And it was just post-Katrina. And here you see Dr. Kline, and I can like almost kind of hear him talking and describing like his NEP, nerve action potential recording, and then like, you know, being very attentive and still very sharp for his late career. So what a nice inspiration. And based on that, I can tell you that Dr. Krishnan has a lot of publication and very novel endoscopic technique, several surgery, including like thousands of nerve operation with advanced technology, especially the endoscopic technology. He has been also the president of the Sunderland Society, as you can see here, one of the most prestigious society. You can see him here with all the colleagues. And then he's been also the course director of the peripheral nerve and brachial plexus surgery at the World Federation in Frankfurt. Here is the cadaver lab and all is scopic equipment, retractors, endoscopic equipment to learn this. Here is the nerve meeting where he was again a leader in this. This is the World Federation as well, PNS meeting in 2018 in Germany. Here is his cadaver lab training session. And I had the chance to be there as well at some point in time to learn this endoscopic technique. And here you see all the leaders as well together in peripheral nerve, like Dr. Sikira, Dr. Skolovsky from Argentina, South America. And then, like, you know, some contribution, of course, all together on papers. Here's a peripheral nerve family. And to conclude that, Kartik is also a father of 3 magnificent children, and behind every great man, there's also a great woman, and Anna is his wife, and of course he has another furry friend to complete the family. So Kartik, I just want to thank you so much for being here with us and sharing your knowledge and all those years of experience. I'm just looking forward to your talk, and I'm really excited to develop some endoscopic treatment here at UCSF based on your experience and what you've done in terms of teaching. So thank you, Kartik. I'm going to give you back the control.
So may I start talking?
I think so.
Yeah, Line, I thank you very much for this wonderful opportunity to be there as a visiting professor at your university. And I'm personally very proud of you, what you have done in this, you know, moving from Canada to San Francisco and building up this unit and making a lot of things possible, and especially also this grand rounds today. So I was initially very worried that there might be some problems with technology and with transmission, because our Wi-Fi is not all set yet. So we are still working on it. So I'm just connecting through some dongles. So I hope it works well. So in order to ensure a smooth course, I had transferred, I had made 2 video files with the assistance of my brother, who lives and works in Amsterdam. That's why you will see Krishnan and Krishnan, it means my brother, and he helped me to make the videos. And I'll ask Teresa to play the video as soon as I finish talking now. And then the first part is about primary nerve reconstruction and primary brachial plexus reconstruction. And then we will have a short intermission with discussion, after which we can go ahead and do the second part, which is the secondary reanimation strategies. So before we begin, I just want to share an anecdote with Dr. Kline. So Dr. Kline, I went to Dr. Kline post-Katrina 2008, and it was exactly the Mardi Gras time. And you know, Dr. Kline is a great surgeon. He's a great everybody. He's a great husband. He's a great surgeon. He's a great father. He's a great friend, and he's a great mentor. He's everybody. So very, very good human being. He told Kartik, I'm going to take you to one of the dinners, and you have to be dressed in tux and tails. And, well, I never wore tux and tails in my life. And he asked me for my size, and he ordered tux and tails for me. And actually, when I put that on first time, and I stood before the mirror, I turned to Nell, his wife, and said, "Nell, somebody's going to mistake me for a waiter." And Nell said, patted me on the back and said, "Don't worry, we'll see that it doesn't happen." And it was a wonderful evening, and I had a great time with Dave, the humble person he is, and he had always supported me. And I'm very, very honored to be a David Kline lecturer at your facility, and I look forward to see more work. And probably we can switch over to the to the talks. I would request Teresa to switch the first video. Can you see it? Can everybody see that?
No, can't see it right
No?
now.
Hang on. Okay, I have to start broadcasting. Now? Now?
Yes, we can see it.
We can see that? Okay.
Good morning. I'm Dr. Krishnan. In this lecture, we will talk about brachial plexus and peripheral nerve lesions, part 1. Part 1 deals with the possibilities and limitations of primary nerve reconstructions. More than 90% of all brachial plexus injuries are aftermaths of close stretch injuries such as high velocity vehicle accidents, internal dislocation of the shoulder joint, and iatrogenic stretch injuries, or open injuries such as stabs, gunshots, and explosions. The brachial plexus is a complex neural structure. It is always possible to restore some function. It is never possible to restore all function. Neural damage can occur at various levels: peripheral nerves, plexus, nerve roots, spinal cord, or the brain. They lead to functional derangements of 3 categories: palsies, sensory loss, neural vegetative disorders. Here, we will focus on restoration of movement alone. The 3 major questions here are: what methods do we have at our disposal? When do we go about the treatment? And what are the techniques of treatment? Let us talk about the muscle and nerve. A denervated muscle undergoes, first, loss of contractility and atrophy, second, connective tissue transformation of the muscle fibers, and lastly and irreversibly, fatty degeneration of the myofibrils. If we put the whole thing on a timeline, we start losing synapses as early as 48 hours after a nerve transection. Muscle atrophy begins to set in from 3 to 4 weeks onwards, and irreversible changes start occurring beginning 1 year after injury. After this time point, there is no use of restoring the nerve, since the muscle tissue stops being receptive to the regenerating axons. I am drawing a red line right in the middle. Before this time, it is sensible to reconstruct the nerve and re-establish the innervation of the muscles, the so-called primary nerve reconstruction. After irreversible changes have occurred in the muscle, movement can be restored only by means of secondary methods, also termed as secondary functional reanimation. Irrespective of the type of treatment, physiotherapy, occupational therapy, exponential current therapy, rehab measures, and professional reorientation play a major role in restoring the patient to everyday life. Primary nerve reconstruction employs 4 basic techniques: nerve suture with or without grafts, neurotization of muscles, and nerve transfers. Primary nerve reconstruction should be performed as soon as possible after a nerve injury, in open injuries, immediately if possible, in closed injuries, ideally within 3 months. Let me take you through each primary nerve reconstruction technique: nerve suture with or without grafts. In this technique, we reconnect the severed nerve ends to each other using microsurgical techniques and electrophysiological testing to see which nerve fiber belongs where. Sometimes a direct coaptation of the nerve is not possible because of a defect injury. In this case, a segment of the sural nerve or other sensory nerve is harvested and transplanted to bridge the defect. This is an example of a traumatic neuroma in continuity of the median nerve. Intraoperative compound nerve action potential recordings showed that no signals could be transmitted across this neuroma. Thus, it was resected and the nerve reconstructed using sural nerve grafts. Nerve regeneration requires approximately 8 to 12 months. This patient incurred a stretch injury to the peroneal nerve, which was also partially transected. You can see the foot drop as the patient walks. Ankle and toe dorsiflexion has become impossible, combined with a less irritating loss of sensation on the dorsum of the foot. In this drawing, you see that a part of the nerve has been decompressed, a part reconstructed with grafts, and a part is used to directly neurotize the muscle. Nerve regeneration takes quite a while to happen. Here we see adequate ankle and toe dorsiflexion as well as a normalized gait without need for supporting splints. This is a more complex injury involving the brachial plexus, where both nerve transfer and nerve grafting have been used as reconstruction options. This is the typical appearance of a patient with a complex brachial plexus palsy with inability to move his injured limb. Approximately 1 year after brachial plexus reconstruction, the patient is able to activate his biceps muscle and the deltoid muscle. Now we come to a technique called nerve transfer. Here, a part or whole of a healthy motor nerve is rerouted into an injured nerve to re-innervate the target muscle. Some clinical examples follow. This is an example of a nerve transfer invented by the French orthopedician Christophe Oberlin. A part of the ulnar or the median nerve supplying the flexor pronator group is microsurgically rerouted specifically into the nerve supplying the biceps muscle, the motor branch of the musculocutaneous nerve. The results are surprisingly quick, provided the quality of the axon donor is good and the time lapse between injury and reconstruction is short. Here you can see the recovery of the biceps muscle. Here we see the recovery of the deltoid muscle after transfer of a few motor branches to the triceps muscle to the motor part of the circumflex axillary nerve. The drawing shows how the nerve transfer of the triceps branch to the circumflex axillary nerve is done and some results following the nerve transfer. Sometimes the problem is too complicated to solve with 1 or 2 nerve transfers alone, like in this patient. He lost suprascapular, axillary, and part of posterior cord function. A nerve transfer has produced some improvement, however, is still inadequate. Here you see the same patient after a secondary reconstruction with free muscle transplant to enhance his functional result. We will see more on secondary functional reanimation strategies in part 2. Stay tuned in. No nerve lesion is like another. The problem is too heterogeneous to attempt cohort studies, thus it is impossible to make specific conclusions. Primary nerve reconstruction strategy should involve an individual assessment of the available axon donors. Stronger the axon donor, better are the results. Reconstruction should be undertaken as soon as possible. Conclusions. Early reconstruction, short nerve grafts, and good quality of axon donors bring forth better results. Complex problems require complex strategies. Surgical reconstruction should be supported by disciplined physiotherapy. Thus, careful planning is necessary, meticulous techniques should be employed, and the follow-up should be very disciplined. In complex cases, plan the enhanced secondary functional reanimation right ahead.
So there I'm back. Right. So, are you able to hear me?
Yes.
Hello?
Yes, we are.
I have a frozen. Okay. So I have a frozen screen of Lean. All right. So that's the first part involving the primary nerve reconstruction. And we could probably do some discussions now, and then move on to the second part.
So Kartik, I saw that you have very nice drawing of your brachial plexus reconstruction. So in terms of data recording, like, are you using electronic recording, or are you putting that like in a file? Like, how do you, in terms of following your outcome, and do you have like, what type of data do you keep, and how do you compare later on like your data?
Well, we have clinical charts. We have muscle strength analysis, of course, which is very useful in comparing the data of how it was before the surgery and how it turns over time. And we put it on a chart and see for every patient. And initially, I had a PhD student who did the analysis of this, and we also published our results. That is my friend and my student, Dr. Martin. You probably know him from Dresden, and he helped a great deal in doing that analysis. And it is not only muscle strength, but also the ability to do certain movement patterns, like picking up something and drinking from a cup, or ability for fine motor functions like writing. So the occupational therapists who treat the patients later, they also have their own methods of assessment. We take that into account. So then after about a year or 1.5, because as I told you, it is not possible to reconstruct brachial plexus as it was. There's always going to be some deficiency or deficits left behind, and we have to address those at different sessions. And we go about setting plans for any necessity for secondary nerve reconstruction, secondary reanimation strategies at a later stage by following up the patients. The good thing in Germany is we don't lose people to follow up, so they come back. They come back and see us, which is not the case as we have seen in Sunderland Society, not the case in many countries with extraordinary surgeons like Brazil or Argentina or India or Russia. They lose a lot of their patients to follow up, which is not the case here. We are able to follow up our patients very well.
So in terms of a database, like, what do you think is most useful? Are you using any special questionnaire to for the function after your procedure, or?
You know, we have this functional disability scale and quality of life questionnaire. We use that for analyzing how, you know, the one thing is the patient comes to you and he's able to perform a biceps flexion, but is he using that? Is he putting that reanimated function to use in everyday life? That is a question. So I know that in Canada they have this, I've forgotten the name of that questionnaire, but we have something similar. We use that.
Is there any other questions on that part from the audience?
I have one. How do you predict the amount of functional loss with the nerve transfer from the muscle that's losing innervation? And do you usually try to pick a muscle that isn't really needed, or do you try to preserve some function?
That is actually a very good question. We don't cut the nerve that thoroughly. I don't know who asked that question. I mean, it would be nice to tell a name or something, because not this easy. Actually, if you pick up a nerve which is quite distal and near the muscle itself, like the posterior interosseous nerve, for example, or the anterior interosseous nerve, then you're going to lose. You're going to lose the function of either finger extension and thumb abduction, or you're going to lose the pinch grip function of your index and thumb. But we don't do that. We go quite proximal at the level of the middle third of the arm, where the differentiation is not that precise. And we open up the nerve by doing a fascicular neurolysis. We open up the epineurium longitudinally, and we select a nerve fascicle which innervates the flexor pronator group, which is basically the pronator teres or supinator, and that is exactly the nerve fiber that we transfer to the. Again, the recipient nerve is specific, which goes into the biceps muscle itself. It is not the musculocutaneous nerve, which is a musculocutaneous nerve, which innervates a muscle and the skin, which is not the sensory and motor nerve. We transfer it specifically to the target nerve, which goes into the biceps muscle just before it enters it. So this way, we are able to do a very specific transfer. So I hope that answers your question. And with passage of time, there is some weakness. I've had interosseous anterior syndrome, Kilo-Nevin syndrome, in one patient who had this type of overland transfer. And I was actually planning to do a tendon transfer for this lady. And suddenly she came back and said, it works. Now I can do the flexion. So I actually presented this patient in one of our peripheral nerve meetings in Germany. So how there's a story of how there was a weakness initially, which recovered later, which means that there is potential for cross innervation and within the nerve itself.
Thank you very much.
Again, I have a frozen picture.
I have a question, if that's all right. Can everybody hear me?
Yes.
Hi, Kartik. My name is Andrew Jacques. I was one of Dr. Jacques' fellows last year, working up in Canada now. It sounds like based on your presentation for a severe brachial plexus injury, you're using a combination of primary plexal repair and nerve transfers. What do you see the role of, for example, in the setting of avulsion injuries, if there is one, direct repair of the nerve root back to spinal cord, for example?
Well, actually, Tom Kalstedt from London, he did some experiments on this by reimplanting the avulsed nerve roots into the spinal cord itself. And we all know Majid Sami, he actually went on to do laminectomies in the 80s and the 90s at the cervical level to see if the avulsion was really there or not. At that time, they didn't have MR neurography and didn't have very specific diagnostic methods to decipher nerve avulsions, nerve root avulsions. I personally do not see a value in reimplanting the avulsed roots into the spinal cord. I don't know if maybe the scientific people from scientific research might think otherwise, because there's been a lot of work going on in this respect on mice and rats, as well as axolotls. So probably Line would be able to answer more of that, because if I'm not mistaken, you spent some time with Tessa Garden, didn't you?
I did not.
So are there basic scientists who will be able to answer that question better?
Yeah. So do you want to move with your second video right now, or?
Sure. I just want to tell you that some of the first few slides are going to be repeated there because the videos were conceived in such a way that they can also be viewed independently. It's just like you're looking at a series of video series, then you say what happened before. So please don't get irritated because of that. So they're going to be, some slides will be repeated, and it's just to give you an idea that to give you a continuity. So should we start the second video? Do we?
Hello, my name is Dr. Krishnan, a neurosurgeon based in Frankfurt am Main, Germany. I'll be talking to you about some neurosurgical diseases based on some examples. Today we'll be talking about brachial plexus and nerve injuries, part 2. We will be talking here about enhanced functional reconstruction after nerve lesions. We know that more than 90% of all brachial plexus injuries are aftermaths of closed stretch injuries such as high velocity vehicle accidents, internal dislocation of the shoulder joint, iatrogenic stretch injuries, or open injuries such as stabs, gunshots, explosions, etc. Brachial plexus is a complex neural structure. It is always possible to restore some function. It is never possible to restore all function. Neural damage can occur at various levels: peripheral nerves, brachial plexus, nerve roots, spinal cord, or the brain. They all lead to functional derangements of 3 categories: palsies, sensory loss, and neural vegetative disorders. Here, we will focus on restoration of movement alone. The 3 major questions here are: what methods do we have at our disposal, when we go about the treatment, and what are the techniques of treatment. A denervated muscle undergoes first loss of contractility and atrophy, second connective tissue transformation of the muscle fibers, and lastly and irreversibly fatty degeneration of the myofibrils. If we put the whole thing on a time scale, we start losing synapses as early as 48 hours after a nerve transection. Atrophy begins to set in from 3 to 4 weeks onwards, and irreversible changes start occurring beginning 1 year after injury. After this time, there is no use of restoring the nerve since the muscle tissue stops being receptive to the regenerating axons. I am drawing a red line right in the middle. Before this time, it is sensible to reconstruct the nerve and re-establish the innervation of the muscles, the so-called primary nerve reconstruction. After irreversible changes have occurred in the muscle, movement can be restored only by means of secondary methods, also termed secondary functional reanimation. Irrespective of the type of treatment, physiotherapy, occupational therapy, exponential current therapy, rehab measures, and professional reorientation play a major role in restoring the patient to everyday life. Primary reconstruction employs 4 techniques: nerve suture with or without grafts, neurotization of muscles, and nerve transfers. Primary nerve reconstruction should be performed as soon as possible after a nerve injury. In open injuries, immediately if possible. In closed injuries, within 3 months ideally. Secondary reanimation techniques involve tendon and muscle transfers and free functional muscle transplants. Unlike primary nerve reconstruction, the techniques of secondary functional reanimation may be used at any point in time, irrespective of the level of nerve damage, the only prerequisite being supple joints. Let me take you through each secondary reanimation technique. Tendon transfers. In this technique, we take a tendon of an intact muscle from the anatomical neighborhood of the lesion and transfer it to a tendon of a muscle that is atrophied. Claw hand deformity results from the lesion of the ulnar nerve or the lower brachial plexus or the C8 and T1 nerve roots. The basic problem is the loss of stability of the metacarpophalangeal flexion. The fingers claw off the moment you want to grasp an object. Eduardo Zancoli from Buenos Aires described the tendon transfer of the superficial flexures to the proximal phalanx, thus substituting the atrophied palmar lumbrical muscles and stabilizing the MP joints to enable grasping. Thus, in hands, the useless hand becomes suddenly useful. Combined with an opponent's plasty, pinch grip becomes possible, which was not before. This is one of the simplest tendon transfer techniques with great long-term outcomes. Using the same principles, tendon transfer techniques are used to correct various hand problems such as claw hand, wrist and finger drop, finger spasticity, and other deformities. Tibialis posterior tendon transfer for foot drop is a classical surgical operation to free patients from braces. Let's move on to local and regional muscle transfers. The principle is quite the same as tendon transfers, only instead of tendons, intact and dispensable or expendable muscles of the anatomical neighborhood are moved to reanimate inanimate movements. This operation is named after a renowned Austrian-American orthopedic surgeon Arthur Steindler. This operation restores elbow flexion. In this technique, the origin of the flexopronata group of the forearm is moved to the distal third of the humerus. The patient is able to flex his elbow as he flexes and pronates his wrist joint. In this example, you see that restoration of the elbow flexion has worsened this patient's shoulder stability, which comes in the package of the upper brachial plexus palsy. This is an example of an iatrogenic injury to spinal accessory nerve leading to shoulder drop and winging of the scapula. The patient cannot stabilize the elevation and lateral movements of a shoulder due to the nerve lesion. However, in the supine posture, when the scapula is stabilized against the thorax with the patient's own weight, the movements are made simpler. Here is the posterior view that shows how hindering the instability and winging of the scapula can be for performing other functions with the hand. Eden in 1920s and Lange in 1950s, both German surgeons, described and modified an ingenious muscle transfer of the rhomboids to substitute for the loss of trapezius function. This video demonstrates the result of Eden-Lange muscle transposition after approximately 6 months. Now we come to a fascinating part where the muscle is carefully harvested and detached from the body and auto-transplanted to the recipient part using microsurgical techniques. This is an example of a long-standing combined lesion of the circumflex axillary and suprascapular nerves. The target muscles are atrophied. The patients have an unstable shoulder or unable to use their otherwise strong arm, complain of pain and unable to abduct their shoulder. Here is a drawing showing the inset of the free functional muscle transplant. This is a 3-operation combined in one. Here the gracilis has been used as neodeltoid. Since the innervation of the transplant has been achieved through the end branch of the spinal accessory nerve, you can clearly see the co-contraction of the neodeltoid together with the trapezius muscle.
Das zieht zwar, jetzt, aber wenn ich jetzt hier drüber bin, ne, dann komme ich bis hierhin.
Okay, wieder zurück.
Ich sag mal, von vom halben Jahr bis vor 6 Wochen konnten sie mir zusehen, dass das besser wurde.
Okay. In this example, the gracilis has been used to restore gross grasping to some extent. The free muscle transplant can be used in several patterns to restore various functions. In rare cases such as this young boy with a flail arm, one transplanted muscle is able to take over several functions. Here he demonstrates the elbow flexion, the same muscle performs finger as well as wrist flexion. In motivated patients with high ambitions for improvement, individual solutions are required, combining all available techniques, sometimes even double muscle transplants as in this case.
Ich möchte da raus, ich spüre das auch, dass da was geht, aber der richtige, wie sagt man, der letzte Schritt ist, will einfach nicht. Ab dieser Position geht's. Dann ist im Prinzip bis nach oben. Dann eben da nach oben geht es auch ohne Probleme. Rüberwärts wie auch da. Nach außen geht es auch. Nach hinten lassen. Weil das spüre ich zum Beispiel jetzt da auch. Da habe ich einen Zug auf diesen Muskeln für diese Außenrotation.
Das klappt nicht beim Sitzen oder beim Stehen.
Nee. Da kriege ich ihn überhaupt nicht hoch.
No nerve lesion is like another. The problems are too heterogeneous to attempt cohort studies, thus it is impossible to make specific conclusions. The strategy should involve an individual assessment of the patient with what we have in hand and which functions we aspire to restore. Thus the surgeon, together with the patient, sets reachable goals, focuses on the techniques, and times the treatment options appropriately. We can achieve no useful results at all with doing a surgical operation alone. Some results are achieved by following up the surgery with physiotherapy. Results get better if we use occupational therapy techniques to the above two. Best results are achieved by combining surgery, PT, OT, and individually designed orthotic devices. I also have to warn you that complications have a direct correlation to poorer results. Thus, careful planning is necessary, meticulous operating techniques should be employed, and the follow-up should be religiously disciplined.
So, I think, can we, Aline, are you there?
Yes, I'm here. So
Okay.
maybe if I can ask you a question about the construction, is that okay?
Yeah, there are some transmission problems, but it's working out fine.
So when you have patients who have a flail arm and has severe avulsive appendixis, what is your strategies for that type of patient? And really often we have patients as well with severe TBI and brachial plexus. So in terms of PT, OT, does it change the fact that they cannot really participate very well? Do you have any like strategies, or are you going to delay those transfers in order for them to recover a little bit more of their TBI? So what's your strategies with that?
So combined lesions with TBI and complex brachial plexus is a question unsolved. I mean, you need the cooperation of the patient. You need the cooperation of the patient to do OT, occupational therapy. So that is very certain. when it comes to the flail arm, there are reanimation strategies, which I have deliberately left in this video one particular option, which we have been working on for years, and it's the exoskeletal system to animate a flail arm. The joints are supple. We try to reinnervate some muscle in the proximal part of your arm, be it biceps or be it pectoral muscles or something, so that the exoskeletal system picks up the signal from this muscle and performs a series of predetermined movements, and the exoskeletal system is fixed to the arm and the hand. As I said, unfortunately, I didn't get the videos in this session, but you can actually Google myoma, that is a German firm which does something like that. Otto Bacchus has started to do something, but the other companies are overtaking that. So for complex, complete flail, when I was in training, it used to be the free muscle flaps, free muscle transplants. We used to transplant gracilis muscle and latissimus dorsi muscle right from the arm into the forearm, like the example I showed you, to reanimate some function whatsoever. And if there is going to be a problem with wrist extension, we put the wrist in a splint or an orthesis, a static orthesis, and let the free muscle flap do the flexion of the fingers. This way the patient is able to grasp something or to put his hand on a handlebar to ride a bike or something like that. But traumatic brain injuries plus complex brachial plexus, do you have any solution for that? Perhaps you can.
Well, I mean, the thing is, what we've done like a preliminary studies in my previous life in terms of classification of those TBI and the outcome of the brachial plexus stretch injury repair. And we realized that, of course, the TBI that are severe needs really rehabilitation prior to attempt, because the outcome is very poor. So, but we had to, in order for the government to accept, like, you know, to do those psychological assessment and then do the, you know, the coping mechanism and then re-educate the patient, we had to do that study. So we didn't change the strategy by itself, but I think, like, I mean, we need to consider that in the picture in terms of talking at least about the outcome on those patients with the family.
Okay. And anybody in the audience has experience with this kind of combined injuries, traumatic injuries combined with complex, not especially brachial plexus, it can also be lumbosacral plexus or paraplegics. Like, you know, the Israelis came up with something called the RoboWalk. You remember that? That was quite a while ago. And they had pre-programmed exoskeletal device which would perambulate the patient. They just strap it to the lower extremities, and the physiotherapists keep the joints supple, and they have a watch that actually programs that device, and they push a button and this thing starts walking, like, you know, a robotic walk. And then there's another program which makes the patient sit and stand up, and there's another program which makes them climb the stairs and so on. So anybody from the audience who have more experience with this kind of complex cases?
I didn't realize they were using it for lumbosacral plexus type injuries, but we have a fairly robust rehabilitation program here in Edmonton where that's exactly what they use is the rewalk for spinal cord injured patients at the thoracic level to try and get them up and walking, like you said.
So how is it controlled? Is it pre-programmed, or do they take the signals from some functioning muscles like that of flank muscles or erector spinae or something?
It's pre-programmed in the case, in the patients that they've used it here for, I believe.
Mm-hmm. Yeah, this is fascinating. This is something which is going to be certainly the future. You know, it's going to be refined more and more. And what I really think is there would be a time when there would be movable joint prosthesis, like motorized joint prosthesis. The motorification of prosthesis would become much smaller and smaller, and if you just implant a joint which can be controlled and which moves by itself and it moves the limbs, that is something which is going to happen in the future.
Is there any other questions from the audience?
Oh, I have one. What is the source of the eventual nerve supply to the free muscle graft, for example?
Yeah, yes, fantastic question. It depends on the axon donor, what we choose as an axon donor. If we have to reanimate, let's say, if we insert the muscle as a neodeltoid, we actually connect the proximal part of the gracilis muscle to the clavicle or to the trapezius itself, and the distal part is inserted with a screw or a corkscrew into the bone, into the humeral bone at the proximal third. So where the deltoid insertion is, that is the muscle insertion. The vessels are connected either to the lateral pectoral vessels or to the transverse colli or the thoracoacromial vessels in the supraclavicular area, and the nerve is connected either to the lateral pectoral nerve or to the end branch of the spinal accessory nerve, so that either you have an extension of your pectoralis major, which pulls the arm up from the front side, or an extension of the trapezius. If you remember, Hanno Melisi had done quite a few of these procedures and published them and showed them. It takes the trapezius transfer, the transfer of the lateral part of the trapezius into the humors. The thing is, it shortens the arm. They just pull the shoulder up there, and there is a visual difference between the healthy shoulder and the shoulder which has had trapezius transfer. So the type of free muscle transfer insert into the neodeltoid is nothing but innervated and vascularized continuation of the trapezius muscle. So this is about neodeltoid, and you can actually use the as neobiceps. And again, the innervation comes from some of the neighboring motor nerve, which is mainly the lateral pectoral nerve, in my experience, when you do neobiceps. And if you insert the muscle for finger flexion, for example, like in Faulkman's contracture, there is ischemic contracture of the forearm and fingers, and then you use the median nerve or the ulnar nerve above the level of the lesioning. So there are also cases where we had to use lengthening grafts. We staged the surgery, like in a complete flail arm, we bring, for example, the motor branches of the intercostal nerves are elongated with the sural nerve graft and brought to the mid part of the arm and left there so that the axonal growth can occur till that area. And after about 8 months, we do the free muscle flap and connect the end of the motor nerve to the gracilis muscle or to the free functional muscle, to the nerve which we had lodged during the previous surgery at the mid area of the arm. So axon donor should be very strong. This is an important prerequisite for success in free muscle transplants.
Is there any other question in the audience? I think that is the end. I would like to thank you so much for doing that virtually. I think it was fantastic. I would like to shake your hand, but I'm going to do that like virtually. And I have a certificate for you that I will send towards you, and a gift as well to be our Kline lecturer. I can tell you that we're going to invite you in person. We have a cadaver workshop following your lectureship, and usually we do that with the visiting professor. But we'll do that later on when COVID situation allow it. So
Yeah.
Go ahead, sorry.
Thank you very much for all this, and I will certainly look forward to the cadaver workshop. And you have been to many of our cadaver workshops, and it was fantastic to have you here. And yes, so I will look forward to the cadaver workshop when you're going to organize it, when this madness is going to end, and we'll be able to see each other in person.
Thank you so much. And also, I'm sure like we're going to be able to do some endoscopic procedure here at some point in time.
Thank you.
All right. Thank you so much, Kartik. It was a fantastic lecture.